starting with the physiology of blood flow today. Again, one of the things that I touched on yesterday that I want you to kind of think in your head is the example of the house. The water main outside the house is going to be your blood pressure, and then the individual stuff, the luggage pressure, is like the dishwasher, the washing machine, the shower, those are going to be the specific tissues, okay? So I kind of want to cover the blood pressure part today, and that'll leave the rest of it tomorrow. And then we should be done with the physiology. Monday will be the lab. We'll do a heart dissection, EKGs. Tuesday will be your exam, and that kind of moves through the rest of the course. Yes, sir?
Well, I was a little bit confused on when shunting happens. Is it all the time?
No. So when you look at this picture, you talk about the meta-arterial and the thoroughfare channel. So you have the precapillary sphincters that are here. These we haven't talked about yet. This is going to be the example of the dishwasher, the washing machine, and the shower. So it's based off of the body's needs.
Okay, so it's like, it's not always going on?
No, it's not always. If it always went on, then the tissue would eventually die because it would be completely deprived of any oxygen and nutrients. So it's only during certain situations that it does this. And sometimes it does it to a certain degree where you don't have it look like that, but it's not complete here.
But if there's not a need somewhere else, then it is circulation.
Yep.
Like that's kind of the baseline.
Yep.
And it's, okay.
Yep. And not necessarily that it's needs somewhere else, it's that tissue right at that particular point needing that blood flow. Okay, and again, we'll spend a lot of time going over it because that's going to be the, again, turning on the dishwasher, turning on the shower, turning on the washing machine. So when we talk about physiology, okay, and again, this is where there's also going to be a little bit more math in this chapter. Again, none of it's really complex math, it's just math. Now, we're going to talk about blood flow, okay? The definition of blood flow is an amount of blood that travels past a certain point in a certain period of time. That's the definition of blood flow. Now I've already exposed you to a term, which is cardiac output. Cardiac output is the amount of blood that leaves the left or right ventricle in a minute. That fits the definition of flow. Now, your book, thank goodness, doesn't get into it. Other physiology textbooks do where we talk about perfusion. Perfusion has to do with flow based off of the amount of tissue that's present. We're not going to spend time talking about that. We're going to leave it very, very simple and sweet. The second one is blood pressure. Now, blood pressure is the amount of force that is pushed onto a certain part of the vessel wall. So pressure over a certain area, okay, or onto a certain area. That's the definition of blood pressure. Now, blood pressure is important because, as it says on the screen, it's a driving force, okay? And the one thing that I've said before, and I want to make sure I reiterate, is that when we think of things from a science standpoint, they generally go from something that's high to low, okay? Gradients. When I have a lot of sodium and I open a sodium door, it goes from a high sodium concentration to a low sodium concentration. We talk about temperature. Temperature goes from high temperature to low temperature. When I talk about pressure, pressure goes from high pressure to low pressure, okay? So when you think about that, this is kind of a very simplistic view of the vascular circuit. I have a pressure at one end, and I have a pressure at the other end. So if we want to be very, very specific about this, this could be one big circuit, is it? That's what we talked about the other day. One big giant circuit. Now, we look at the difference between these two pressures, okay? And it's often just referred to as the delta P. Delta means change. P is the pressure, so the change in pressure. The change in the pressure from P1 to P2. This has to be higher. If P1 is not higher, blood will not go round and round. And it should make sense because when we really look at it, and you don't have to write this number down yet, but because we have to talk about it, but a mean arterial pressure of 93 and basically 0 to 5. Huge difference. Therefore, blood goes from an area of high pressure to an area of low pressure. And the last one is resistance. Resistance is something that impedes blood flow. If I didn't really have a resistance, I probably wouldn't have a blood pressure. That's one of the things that helps drive the blood pressure up. And I've already talked about things that have a tendency to affect resistance. We have the stuff inside the tube, the viscosity, the thickness of the substance inside the tube. Because again, we're going to use an equation I'm going to show you in just a second when we get into pulmonary physiology. The only difference is, in pulmonary physiology, I have air moving through a tube. Here I have blood moving through a tube. I can remove this completely from physiology and just talk about physics, and I can put any substance in the tube. And all of this still applies. So viscosity. Do you suppose that my blood viscosity changes at any given time? I mean, instantaneously? No, not instantaneously. So for the most part, we don't really pay a lot of attention to blood viscosity except for over the long haul. But instantaneously, it doesn't really affect my blood pressure. How about the length of the blood vessel? So remember we talked about this, that the blood vessel, the longer it is, the greater the resistance. Do you suppose my blood vessel just immediately gets longer? No. I mean, it does as we get older, but that's pretty much it. It's not like I'm sitting here and suddenly like, oh, I think I felt my aorta get bigger. It doesn't work that way. Okay? The last one is diameter. Okay? Now, diameter is important because if you notice the equation here is that we've got resistance is equal to 1 over r to the 4th power. Does anybody know the significance of this right here? Everybody understands what a radius is, correct? So when we look at a radius, a lot of times we talk more about the diameter. That's why the diameter is here. Diameter is just this distance from one side to the other. The radius is just half of that. So that's the diameter. So we look at the radius because it contributes to the diameter. What is the significance of r to the 4th power?
The greater the radius, the lower the resistance is going to be.
That's the overall idea. You're correct. But what's the significance of it being raised to the 4th power?
Exponentially.
So it is exponential, but what else? So there's something specific about it being exponential. A small change in the radius of the diameter causes a huge change in the resistance because it's to the 4th power. So as we've talked about before, if you've not quite got the whole fractions thing down, and it's still providing you a little bit of concern, you know, again, you can plug the numbers in. But as this number goes down, so as it gets smaller, the resistance goes up. And again, it's dramatic. Why is it dramatic? Because it's raised to the 4th power. So that would, you know, if it was 2, and I'm sure everybody understands exponentials, but if we had 2 to the 4th power, that's 2 times 2 times 2 times 2. So it's a huge change. When we get into respiratory physiology, we'll talk about this to a greater degree because it affects airways even bigger. If I have something that's stuck in a patient's airway, or I have mucus, or I have secretions, or I have fluid, what have you, a peanut that's stuck in there, especially in a pediatric population, this is going to change how much air is able to move through because of that 4th power. you can plug the numbers in to kind of see what happens. Resistance is not a good thing. Resistance impedes blood flow. It's a good thing in that if I don't have resistance, I don't have a blood pressure. If I don't have a blood pressure, the blood doesn't go round and round. But I can go to the opposite extreme where I have too much resistance. And the heart's having to work too hard to pump blood around the rest of the body. Okay? And again, you can certainly plug those numbers in, make them up, and see what happens. I wouldn't use the number 1, because that's not going to get you very far. You might use it at the beginning. 1 over r, or 1 over 1 to the 4th power is still going to be 1. But if you shake it up to 2, you'll see that as that number goes up, resistance goes down, and vice versa. Okay? And this is the thing that I started off the lecture yesterday with the fact that, you know, when we move through our arteries, we go from our elastic arteries to our distributed arteries, or muscular arteries, to the arterioles. And I said that even though the muscular arteries have a greater amount of muscle in their layer, remember we looked at those same kind of 4 general things that make up the components, arterioles still contribute much greater to the blood pressure. Why? There's far, far more of them than there are muscular arteries. Okay? So the formula that we're going to kind of play around with is going to be this formula here. Flow is equal to the delta P divided by resistance. And what I would encourage you to do is to start understanding not how to do the math with fractions, but how fractions work. So if you're not quite sure what the relationship of the numerator is to the number on the other side of the equal sign, let them plug numbers in. The easiest thing to do if you don't want to plug the numbers in is to just understand that as the numerator goes up, flow goes up. So if I increase the difference between P1 and P2, my flow is better. I have more flow. If I decrease it, I decrease flow. So the number on the top, if I change it without changing the bottom number, is going to change the flow in the same direction. Whereas the denominator is the opposite. If I increase resistance, it decreases flow. If I decrease resistance, it increases flow. It's inversely proportional. So the top one is proportional, meaning that if one goes up, the other goes up. The one on the bottom is inversely proportional. And again, all you have to do, if that doesn't make sense to you, is simply plug in the numbers. So if we do that, let's just say delta P is 1 and resistance is 1. 1 over 1, it means my flow is 1. If my delta P goes up, 2 over 1, flow is 2. So you should see that as this number goes up, that number goes up. And then just plug a number in for the bottom. So if you have 1 over 2, so we left the delta P there, it goes down. Just simple. Again, I'm not asking you to do, again, you will be doing math, but I'm not asking you to do super important math. I'm asking you to get the principles down. And this is going to help you as you just move through science. The more you understand how fractions work. Because a lot of times all you're doing is trying to make a rough estimate of what's going on. In other words, I care more not what the exact number is, but what the direction is. Okay? Yes, ma'am.
So if this is given on a test, you'll give us the numbers we just have for like delta P and R. So we just have to solve for that flow.
I won't give it to you.
Oh, okay.
I mean, you'll have to, what might show up on the exam is I want you to explain this equation to me.
Okay.
So you should be able to tell me that, you know, this is the change in pressure from one side of a vessel to another side of the vessel. That's why the delta P is here. So again, anytime in science you see this triangle, it means change. A delta. So what is the change in pressure from the beginning of the tube to the end of the tube? You just simply do the subtraction. And then you should be able to talk to me about resistance. That's the physiology part of the class, is being able to walk through this equation. Okay? Now, when we talk about blood pressure, again, this is the water main outside the house, so that you can take your shower, you can do the dishes, you can wash your clothes. It has to be high enough to bring water into your house. And that's what we're talking about here. Now, some of the numbers. So when we talked about cardiac physiology, we talked about systole and diastole. What chambers were we referring to if I just say systole and diastole? The ventricles. So even though the atria undergoes systole and diastole, usually we put the word atria in front of it. If there's no word in front of it, we are referring to the ventricles for both. Systole is contraction, diastole is relaxation. Diastole is when we're filling the heart. When we talk about blood pressure, we have a systolic blood pressure. This is the blood pressure on top. This is the blood pressure in the vessels when the heart is contracting. It's always measured in millimeters of mercury here in the United States. Keep in mind that if you're ever reading medical journals, medical reports from other countries, they use different ones. Some use kPascals. We use millimeters of mercury. It's just a measure of pressure. Okay? And again, the top number is a systolic. What's happening during contraction as blood is being ejected out into the blood vessel. And then diastolic is what's occurring during the relaxation phase. Now, just as a point of knowledge, your blood pressure really is 120 plus 760 over 80 plus 760. Anybody know what 760 is? It's atmospheric pressure. So we don't have numbers that are too big. We always just wipe out whatever atmospheric pressure is. That's why we always look at it from this number here. So when we get into any pressuring, we do the same thing in the respiratory system. We always kind of erase the 760 because it just makes the number too large. But really we're talking about above atmospheric pressure. So your blood pressure would be, 880 over 840 is a real blood pressure. But too big of a number, so we just look at it from this standpoint here. Okay? Now, a couple numbers and a couple things you have to learn how to calculate. Next one on there is called pulse pressure. And a pulse pressure is the difference between these two. So if the blood pressure in my vessels at rest, I wouldn't really be feeling anything, correct? But when I feel a pulse, which is my systolic, it's the difference between these two things. So the greater the number, the stronger your pulse. So if you ever hear somebody refer to their pulse as being bounding or thready, thready is a very weak pulse, which means my pulse pressure would be very, very narrow. Usually both blood pressures are down. You might have a blood pressure of 85 over 60, which would give you a pulse pressure of 20. Think about your pulse pressure as being a trampoline. If you're on the trampoline, the base is your diastolic blood pressure. As you jump up, that's going to be your systolic. So the difference between the height that you're jumping is your pulse pressure. And if I can jump higher, it's probably going to feel stronger. Now, the next one is the mean arterial pressure. Your book uses one equation. I use a different one. They don't like the one that I use. I like it because it's still fairly accurate and it makes sense. So this is not a blood pressure that's angry or upset. Okay? So in science, when we hear the term mean, it means what? An average. How do I calculate an average?
Add them together and divide.
You add up what together?
Numbers.
I do add up the numbers, that's correct.
Systolic and diastolic.
So just in general, if I'm talking about just a mean, I add up the numbers that are involved and I divide by what? The number of numbers I used, okay? So to be able to calculate this, there's one important thing that you need to be aware of, which is we spend more time, twice as much time, in diastole than we do in systole. Okay? So in that particular instance, we should probably calculate it twice. So the easiest equation is I'm going to take my systolic blood pressure, I'm going to take my diastolic blood pressure, and I'm going to add it twice. How many numbers do I have then? So I'm going to divide by 3. It's probably the easiest way to calculate a mean. As your heart rate starts to go up, this equation doesn't have as much accuracy. But you would have, if we were to do this, you'd have 120 plus 80 plus 80. Which would be what? What's the number? 280 divided by 3, probably going to come out to be about 90. 90 millimeters of mercury. 93 millimeters. Now the one in your book is a little bit more cumbersome. Diastolic plus 1/3 of your pulse pressure. See how the mean makes a little bit more sense? Because everybody knows how to calculate a mean. This one doesn't make as much sense. A little harder to derive as far as where the derivation comes from. Okay? You can use either one, but pick one. This is one, by the way, that you will have to do. You will have to be able to calculate the pulse pressure on an exam. Again, very straightforward. Can't use your phone. If you think you need a calculator to do simple math, that's perfectly fine. Just bring a calculator. Okay? You also should be able to calculate the mean arterial pressure. So you should be able to either do this math here in your head, or bring a calculator, or do this math. And yeah, I would be giving you the numbers for that. Now, why do I need to calculate a mean? Because what you should hopefully notice is that when I calculate a mean, I've removed systolic and diastolic completely. It's now just a number, 93 millimeters of mercury. The reason that we calculate it is because if you look at this particular diagram, as I start to move through the circuit itself, when I say the circuit, I just mean the long tube, the vascular system. We have a systolic and diastolic up here. That's what these two lines represent, systolic, diastolic. That exists until you get to the arterioles and the capillaries. Well, it's pretty difficult to compare apples to apples if in the beginning of the circuit I'm using 120 over 80, and then when I get down to the arterioles and the capillaries, there is no diastolic. There is no systolic. There's just one number. That's the reason why we convert this to a mean. Because then I can use the mean to compare the blood pressure inside the whole entire circuit, from one point to another. So for those of you who work in the hospital, those of you who are pre-hospital, especially if you do your blood pressures automatically, once you blow the cuff up and it starts to decrease, usually the printout is like that, or the readout. This is your mean arterial pressure. Machine's automatically calculated. So it allows for a comparison. And I would like to say that it's used mostly physiological, or from a physiology standpoint, a classroom standpoint, but there are some physicians or some surgeons that prefer mean. So instead of a physician writing an order to say, I want my patient's blood pressure to be kept, in a certain range from a systolic diastolic, they say, I want my mean arterial pressure kept, greater than 65. Doesn't really make a whole lot of difference from a clinical standpoint, except it's just one number that you're doing. But you should know where you get the number from. So if you're in the intensive care unit, again, we usually stick tubes in every little orifice that you've got, and we usually monitor your blood pressure. But even if you were to do it just with the blood pressure cuff, the automatic, you're still going to get a reading from that standpoint. So the purpose, comparing apples to apples along the whole entire pathway. So as we start to move down, you notice this blood pressure is going to decrease dramatically. The mean arterial pressure. So here it's 40. We have, if you have a normal blood pressure, 93 up in the bigger vessels. Yes, sir.
So you can start in that graph. You can start where that curve is going to be based off of that number, 93.
What do you mean?
So if is it going to follow that same pattern, that line, where they meet up and then fall down, and the blood pressure goes down for the venules and the veins and whatnot?
Right. So as you go through the system, they will the pressure will degrade, and it should, because pressure's moving from high to low.
And so that number, the 93 millimeters per mercury, is that going to shift the entire structure up and down depending on what the initial
Yes.
blood pressure is?
Yes.
Okay.
Yep. Absolutely. So when you look at the capillaries, again, we have a much, much smaller pressure here. It's not going to be pushing out as much as it would in the larger vessels. And again, they tend to be very, very fragile. This is one of the reasons why it's easy to get a bruise if you get hit in certain places, because those vessels that are closer to the skin, those capillaries are very fragile. So a burst, and then you'll have more flow that tends to be leaking out of them. If not, the lower pressure, once we get to the tissues, which is what the capillaries are, they're exchange vessels. So again, the analogy I've been using and I'll continue to use is the flight attendant. It allows for you to kind of have more time to distribute things moving out. I can hand out the peanuts and the drinks because I'm not in such a hurry. Now when we look at the veins have to even be a lower pressure than the capillaries. Why? Things move from high pressure to low pressure. So we have arteries, capillaries, veins. If I want to get stuff back to my heart, the veins have to be even lower pressure than the capillaries, or else blood is not going to come back to the heart. So it continues to degrade. The pressure continues to degrade as you move all the way through until you get back to the superior and inferior vena cava, where it's returning back to the right atrium. Now, two things I talked about yesterday that facilitate this process, because remember, as I'm standing here, I have my blood trying to come back up to my heart against gravity. So two things occur. The first one was that respiratory pump. Remember I talked about the main bridge reflex, the atrial reflex, that causes slight irregularity in heart rate because of our breathing. So when I take a breath in, it creates a negative pressure inside the thoracic cavity. That negative pressure is then transmitted to the great vessels. Superior vena cava, inferior vena cava, even to a certain degree of pulmonary veins, aorta, and that's going to cause blood flow to come back to the heart. It's called the respiratory pump. The second one was the muscular pump. That was when we had these valves, and again, it's specifically to the appendages. We do have them kind of scattered about, but the greatest concentration is in the appendages, and even then, we have them probably a little bit more in the legs than we do in the arms, but we have the muscle contraction as you move around, as you lift your arm up, as you bend your arm, that's going to push blood up. And then the valves that are present there is going to prevent blood from coming back. So that's the muscular pump. Two things that facilitate blood coming back, because the venous system also has to work against gravity from that standpoint. Now here's where we're going to get into a little bit more of the math, okay? And if you're a little bit math phobic and it doesn't make sense to you, I'm not going to lie to you. So what I'm going to tell you is occurring up here does occur. It's not magic, all right? So we're going to look at blood pressure. That's what this first part is about. Remember, we talked about making sure that our water main has enough pressure to bring water into the house. So if I want to figure out what contributes to a blood pressure, I probably want blood pressure on one side of the equal sign by itself. Well, when we look at this equation, flow is equal to the delta P divided by resistance. We already talked about what the flow is. Remember at the very beginning I said blood flow is the amount of blood that passes a certain area in a certain period of time. And we have one already defined, which is our cardiac output. A certain amount of blood that leaves the ventricle every minute. So instead of flow, I can put cardiac output there. Simple substitution. So far, we're just saying now that the cardiac output is equal to the change in pressure divided by resistance. The change in pressure is my blood pressure. So if you want, you can cross out delta P and put in BP for blood pressure. And then what we're simply going to do, since I want blood pressure by itself, is I'm going to multiply both sides times resistance. And when I do that, it gives me my blood pressure. So what are the variables that make up my blood pressure? Cardiac output times resistance. So this is a product equation. In other words, it's a multiplication equation, which makes it a little easier to understand than the division equation. So now I understand that if I increase anything on this side over here, it's going to cause my blood pressure to go up. If I decrease any of these things, it's going to cause my blood pressure to go down. Now, just to kind of make it a little bit easier in the long run here, well, maybe not easier for everybody. So that's the equation we're working with. Blood pressure's on its side, or on one side, so I know how are we going to change my blood pressure. I'm going to affect these two variables. Now, does anybody happen to remember what the formula for cardiac output is? Stroke volume times heart rate. Okay, remember cardiac output is the amount of blood that leaves the heart every minute. The amount of blood that leaves the heart every beat is called the stroke volume, and a heart rate is what is your pulse, what is your actual contractions per minute. It's the definition of a heart rate. So I can rewrite this actually and say so now I have three things that affect my blood pressure. And if I change any of those, so if I increase my heart rate, I increase my blood pressure. If I increase my stroke volume, I increase my blood pressure. If I increase resistance, I increase my blood pressure. And again, if those don't make sense to you, on your notes I would probably have this equation written out, and I would probably write Increase, 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 causes an increase in blood pressure. Decrease, 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 causes a decrease in blood pressure. Yes, sir.
Does one of those outweigh the other? So if one of them was increasing and the other and another variable was decreasing, does one have more influence?
The one that probably has the biggest influence is going to be our resistance. But we don't generally spend a lot of time in compensatory mechanisms. So in other words, well, what happens if my heart rate goes down? Well, more than likely the stroke volume goes up. So these two things interact more closely with each other. But overall, resistance has the largest impact because of our arterials and the ability to change it. So as we go through here, to calculate how we might be able to maintain our blood pressure, it's going to affect these three variables here. And that's the way that I want you to learn this as we go through or to practice it. Okay? So we're going to break this down into short term and long term. And in short term, we're going to break it down from the standpoint of our nervous system and chemicals. So here, in our nervous system, remember that we had the cardioacceleratory and cardioinhibitory centers in the medulla, and they are going to interact with the parasympathetic nervous system and the sympathetic nervous system. And again, I stated the other day, I don't want you to get too lost in the fact that the parasympathetic actually emanates from the medulla, whereas the sympathetic is as a sympathetic trunk ganglion chain that you don't have to worry about. In blood vessels, specifically in the arch of the aorta, and in what's referred to as the bifurcation of the carotids. Fancy way of saying where the common carotid turns into the external carotid and the internal carotid. So bifurcation just means dividing. We have special cells that are present that detect pressure changes, and they're called baroreceptors. Okay? You actually have them in most blood vessels, but they have the most important function in the arch of the aorta and at the bifurcation of the carotids. So we have them on both sides. These things are going to detect changes in blood pressure, and then it will elicit a response. So when we talked about sensors in the peripheral nervous system, I told you that this is a reflex. As I'm standing up here, as I walk across the room so I don't pass out, my body is constantly looking at my blood pressure to be able to regulate. I need more blood flow to the brain. I need more blood flow to the body. I have no idea that that's occurring. Those are reflexes. Now, when we look at the baroreceptors, so this just happens to represent the ones that are at the bifurcation of the carotids. When my blood pressure goes up, so these cells are being exposed to a larger pressure pushing down on them. This is kind of like the photoreceptors. They then send impulses to the medulla. They turn off the cardioacceleratory, so the thing that's speeding up the heart, and they turn on the cardioinhibitory. So what are some of the ramifications for that? Well, when we go to the heart, since I'm decreasing the amount of sympathetic stimulation to the heart, the heart rate goes down. What happens if my heart rate goes down to my blood pressure? Blood pressure goes down. I decrease the contractility. In other words, my heart, instead of squeezing on the ventricles like this, might be just going, just like that. What do you suppose that does to my stroke volume? Decreases my stroke volume. If I decrease my stroke volume, what does it do to my blood pressure? It causes it to go down. via my alpha 1s, I change the rate of firing to the smooth muscle of my blood vessels. They don't contract. When they don't contract, the diameter of the blood vessel gets bigger. The radius gets bigger. What does that do to my resistance? It goes down. By the way, that term is called vasodilation. Vasodilation is because smooth muscle relaxation. So the diameter gets larger. The opposite, when I have contraction of the smooth muscle, it causes vasoconstriction. Vasoconstriction means the diameter is getting smaller. Now, if my blood pressure is too low, bless you, then my baroreceptors are not being stimulated. When they're not being stimulated, the cardioacceleratory is always, it's not being stopped. So it's now on. So again, that's why I say it's kind of like the photoreceptors. It actually has to be inhibited to turn it off. So since it's going to be turned on, I'm going to go to my heart, and I'm going to increase my heart rate. If I increase my heart rate, what does that do to my blood pressure? It increases it. I'm going to increase the force of contraction. I'm going to squeeze out more blood, which means my stroke volume will go up. And if my stroke volume goes up, what does my blood pressure do? Goes up. I'm going to go to my blood vessels. I'm going to increase the smooth muscle contraction. That's going to cause vasoconstriction. So the diameter, the radius, goes down. When the radius goes down, my resistance goes up. If resistance goes up, my blood pressure goes up. And that's basically how I would put those in your head. I would make sure that you have this equation written out. And if you need to, you know, maybe over here with resistance, you have that equation so that you can walk through each step. You don't just memorize. You understand that, again, increase in heart rate, I go over to my equation, increase in heart rate means an increase in blood pressure. Now we also have chemoreceptors, and they're actually located in the exact same spot as the baroreceptors. There's one more we'll talk about in the respiratory system. They're called central chemoreceptors. But here, these are located essentially in the arch of the aorta and at the bifurcation of the carotids. And they detect the acid base, so the pH of the blood. They detect oxygen and carbon dioxide levels. So when my pH goes down, which means my blood tends to be more acidic. When my carbon dioxide level goes up, and when my oxygen goes down, those things will increase the activity of the medulla. They will increase contraction, increase stroke volume, increase heart rate, increase resistance, so the blood goes round and round. Now, from a chemoreceptor standpoint, I do not need you to tell me what direction these things are going to move. Because we really haven't talked about how these have these interactions. Now, I showed you that equation that I told you were going to have to eventually come back and bite you in the butt over and over again. But anytime I have an increase in this, I have an increase in that. Anytime I have an increase in that, causes my pH to go down. So we really haven't spent a lot of time talking about the connection. We will in the respiratory system in AMP3. So I care that you know that the chemoreceptors, where they're located in the exact same spot as the baroreceptors. They detect, obviously, chemicals, and from that standpoint, they're going to cause the same response depending on the direction you're moving. Now, just to kind of put it in your head, why? If I have a decrease in oxygen, I want to pump more blood round and round. I need a higher blood pressure to get more oxygen to the tissues. Carbon dioxide is a waste. And see how it affects my pH. So if carbon dioxide levels are going up, I need my heart to pump blood faster and harder, which it's going to do because our driving force is our blood pressure, to get rid of the carbon dioxide. That's the rationale behind it. But on an exam, I do not need you to tell me what direction these things need to move to have that response. I just need you to understand where they are and that they respond to chemicals and will affect my blood pressure. Now the baroreceptors, you should be able to walk me through this diagram here. Now, you remember I showed you a picture, I think it was in the cardiac section. This is another one of those ones that you can either redo or flip, but it tells you the exact same thing. So mean arterial pressure is my blood pressure. So this, what you're seeing up there is this equation. It's just flipped. So blood pressure is made up of cardiac output times resistance. Cardiac output is made up of stroke volume and heart rate. Resistance, blood vessel diameter, blood viscosity, blood vessel length. And out of all of those, out of those three that you see up there, diameter, viscosity, and blood pressure, which is the one you think changes the quickest? Diameter. Because I already said my blood does not get thick immediately. My blood vessels don't grow longer immediately. But the diameter of the blood vessel can change like that. That's why if you're a healthy individual, it's not a big deal to go from a sitting position or a laying down position to a standing position fairly quickly. The older you get, so those of you who take care of patients, you don't just get grandma out of bed. Okay, Trace here, let's get you up in the chair. When you get little old people up, what do you generally do? You get them up and they sit them on the edge of the bed for a minute or two. Kind of get their bearings straight. Then you help them up. Because if you get old people up too fast, they don't have this vasoconstriction that can happen in their legs. That resistance, increasing the resistance to shove blood up to the brain. So when that happens, when they don't go up to the brain, they get dizzy or they can actually pass out. Okay? That's the response when you go from a laying down position to a standing up position, is this massive vasoconstriction that's going to occur to shove blood upward so that it's still going to the brain. But this is an excellent diagram that pretty much is all of this information right here. So I told you our short term was going to be divided into our nervous system and then chemicals. So these are chemicals that are actually going to facilitate or affect our blood pressure. So the first one is norepinephrine. Now if you want, you can put right after it epinephrine, because they are chemically different, but they act roughly the same. Okay? So remember the receptors that I told you that we generally look at when we talk about the sympathetic nervous system was our beta 1s, beta 2s, and alpha 1s. Remember, beta 1s we find in the heart, beta 2s, and it's not the only place, but it helps to make the differentiation, specifically when we're talking about vascular physiology. Beta 2s in the lungs, alpha 1 in the vascular space. So from that standpoint, epinephrine actually hits all of these equally. And this is not going to show up on the exam. I just want you to know that there is a difference between them. They're both considered catecholamines. Norepinephrine, much greater alpha. So I can give epinephrine to somebody in a cardiac arrest, and it's going to stimulate their heart, it's going to stimulate their blood vessels, it's going to stimulate the pulmonary system. If I give somebody norepinephrine, it's going to have its biggest effect here, which is my vascular system. So norepinephrine is going to cause my blood pressure to go up. Why? Because it increases my resistance. How did it increase resistance? It decreased the radius. Because it went like this to that. Radius went down, resistance goes up. If resistance goes up, blood pressure goes up. That's why I said, to me, when you're studying this, if you don't have this written out like this, and it doesn't have to be as messy as mine, I mean, you can have it be that. Okay? Increase or decrease the diameter, decrease the radius, it increases resistance. If I increase resistance, it increases my blood pressure. And that truly is how I would encourage you to study this, because it's going to put everything in more of a concept map. It's easier to understand. Now, the one thing that I didn't talk about, see the word peripheral resistance here? It means resistance. That's what I'm referring to with resistance here. Peripheral resistance just means that which is in the periphery of the body. Every place out here. We add the resistance up together. Okay, because I can do these calculations. If I had a patient in a critical care unit, I can do these calculations. You can also put something in the patient that monitors what the resistance is. So you might see total peripheral resistance on an exam, TPR. TPR means resistance. It just means resistance. Now, second one. Atrial natriuretic peptide. Very, very long word. So let's break it down. We have atrial, which probably has to do with the atria. Natri has to do with sodium. That's why sodium on a periodic table has an Na on there instead of an S for natrium. That's the word for it. Uretic means P. Okay? So this essentially is going to increase sodium removed from the body. And there's something that you should probably start sticking in your head, because it's going to come back over and over again as we move through this chapter and as we move into ANP3, which is where sodium goes, water goes. So if I get rid of sodium, I'm going to get rid of water. If I get rid of water, what do you suppose that does to my stroke volume? Decreases it. Because remember, blood is about 50% water. Plasma. Plasma is 50% or 95% water. So if I decrease my water content, I'm going to decrease my stroke volume. If I decrease my stroke volume, I decrease my blood pressure. ADH. Diuretic hormone. So again, let's break that down. Anti means what? No. Diuresis means to pee. Hormone's a hormone, so this is a no pee hormone. It decreases the amount of urine that's formed. So if I'm not getting rid of water in the form of urine, it stays in my body. If it stays in my body, what do you suppose it does to my stroke volume? Makes it go up. If my stroke volume goes up, my blood pressure goes up. We have one called angiotensin II. Okay, so we will spend a lot of time in the renal system talking about angiotensin II. Angiotensin II is a very potent vasoconstrictor. So if it causes my blood vessels to get smaller, what does that do to the resistance? They go up. If my resistance goes up, my blood pressure goes up. Now it does an awful lot of other things. Okay? It increases, and you don't have to write them down. What I want you to know is it's a vasoconstrictor, so it increases resistance, but it increases my release of antidiuretic hormone. It increases sodium reabsorption. It decreases my peritubular hydrostatic pressure. It does a lot of things that essentially do what? Cause my blood pressure to go up. This is part of a system called the renin, angiotensin, and sometimes we put in the term aldosterone, so sometimes it's the RAS, sometimes it's the RAAS, renin, angiotensin, aldosterone system. So you're going to see that a lot in the renal system. Okay, bless you. The last one is called nitric oxide. This is not the stuff you get at the dentist office, which is nitrous oxide. Nitric oxide is a vasodilator. So if I cause my blood vessels to get bigger, what happens to the resistance? It goes down. If my resistance goes down, my blood pressure goes down. So when you look at this, the first one, norepinephrine, causes my blood pressure to go up. Atrial natriuretic peptide causes my blood pressure to go down. Antidiuretic hormone causes my blood pressure to go up. Angiotensin 2 causes my blood pressure to go up. And nitric oxide causes my blood pressure to go down. Now, those are the short-term mechanisms. In other words, what happens minute to minute to keep my blood pressure either from going too high or going too low. Okay? I have long-term. In other words, let's say that I have a chronic blood pressure problem and I'm not going to continue to do this. So the body's way of handling this is this process here, which is going to increase my arterial blood pressure. Now your book has changed over the last year. This used to never be introduced here. It was always introduced in the renal system, which is AMP3. In fact, I always have to remind myself when we're going through the renal system to make people come back and go over this diagram, because it's in the vascular chapter. You do not have to know this. This is that whole thing I was just talking about with the renin, the angiotensin, the aldosterone. Okay, so again, we're going to release renin here. Angiotensinogen becomes angiotensin 1, angiotensin 1 becomes angiotensin 2, and angiotensin 2 has these effects. All of them are going to do what? Increase my blood pressure. Okay? So it's going to affect my water volume over long term. So when you see the thing that says long term, it's the kidneys. Kidneys are what's going to affect my blood pressure overall. That's the take-home message for long term. Again, you do need to know these chemicals. But in in your chapter, if you have the newest textbook, you're going to see this mess here. I'm not asking you to know this mess for ANP2. You will know this mess ad nauseum for ANP3. I will tell you, just to kind of wet your whistle a little bit, that the hardest test that you will take in ANP1, ANP2, and ANP3 will be your fluid, electrolyte, and renal chapter. That is the hardest test, hands down, of any test that you take, because it's almost all physiology. And everybody says it over and over again. And those of you who are going to take me for ANP3, which by the way, the schedule is fixed, so apparently the class is already full, so I'm hoping people just automatically joined in. But I will be teaching ANP3 Tuesdays and Thursdays from 1 to 4. But we'll spend a lot of time with that, and I will say it over and over again. I'm saying on the first day, I'll say every single time, so that you know that the third exam is going to be the hardest exam you take. Now, this is basically what I just talked about. This is another one of these diagrams that is just valuable, because it's going to improve on this small one here by adding all the things that could potentially occur up there. Blood pressure, made up of resistance and cardiac output. These two things, stroke volume and heart rate, make up cardiac output. These are the things that are going to affect cardiac output. What affects these? These things up here. Resistance, diameter of the blood vessel, viscosity, length. These are the things that will affect that. Those are your chemicals right up there. Epinephrine, norepinephrine, antidiuretic hormone, angiotensin II. Those are going to increase. That's the reason nitric oxide is left off, because this is specifically showing things that are going to increase my blood pressure. Now, I'm just going to spend the last part of the class talking about assessing blood pressure, then we'll be done. So that's why I'm not going to take a break, because we'll be done in about 10 minutes. Okay? And then tomorrow, I will be talking about how we turn on the washing machine, the dishwasher, and the shower. All of these things we're making sure that I have pressure outside my house to bring the water into the house. So blood pressure makes blood go round and round. Now we're going to figure out, when do I shunt my blood? Why would I shunt my blood? That's what we'll talk about tomorrow. But I'm just going to finish this clinical component here because it's very, very quick. So blood pressure. Okay, we assess our blood pressure. One of the easiest ways to assess a blood pressure without getting a number is just simply walking over to somebody and taking their pulse. If I can feel a pulse, specifically a radial pulse, they have a blood pressure. Blood's going round and round. Okay? Now, there are some people that will have blood go round and round, and I can't feel a blood pressure because it's so weak, and that's when you get a thing out called a Doppler. Bless you. So if you've never seen it, it's just basically the nurse is going to put on a little headset thing, and we're going to take a little gel, put it over where we think the vessel is, and then it's basically an amplifier. And you hear this, and it's just showing you the blood is moving through that vessel. But if I have to do that, it means that my blood pressure is fairly low. So those of you who have taken care of patients, you might have seen patients that have little X's on the top of their feet at the dorsalis pedis. It's not because there's a little treasure underneath there. It's because it was hard to find the blood pressure, the pulse. So the nurse who was taking care of the patient, when they got the Doppler out and they found him, they put a little X there, so they helped somebody else go, you don't have to sit there and feel forever and a day. You can simply go, oh, there are the X's. Yeah, blood pressure seems to be fine, or their pulse seems to be fine. Okay? So that's how we start to assess perfusion. Okay, and there are a variety of places that you can assess perfusion at. So these are the pulse points. The most common is going to be the brachial, the radial, and the femoral. Femoral is usually done during cardiac arrest, during when a patient's not doing well, because we don't like to fillet the patient open as far as their clothes goes and have them be naked. But the patient obviously needs to be disrobed to be able to feel their femoral pulse. Carotids we generally do again during resuscitations. It's not a good idea to use your carotids to check pulses, because if you're not very skilled at it, one, most people don't like to do it because they don't want to have to commit and say, oh, I don't feel a pulse, and someone's like, it's right here. So carotids, if you just find your trachea, just right at the base of the trachea. The problem is that if you push too hard, you can actually slow the heart rate down. Okay? It's one of the reasons why unless you're really good at taking pulses, you probably shouldn't use carotid. But you have facial, which is kind of the cornea, temporal up here. Axillary is hard to feel, but it is right in your armpit, and you can sometimes palpate it there. Brachial is the one that we generally palpate when we're doing blood pressures. Not everybody palpates it to feel it. They just put the stethoscope there, and they just, oh, it must be here. Radial, femoral, popliteal. You can feel down the back of your knee, and you should be able to palpate it. We have the posterior tibs, which are right here, and then we have the dorsalis pedis. So that was what I was referring to, that if you have a patient that you're taking care of that had vascular surgery, it's very, very common for the surgeon to come in, and as they're getting reported again, they usually slide their hands, and they're feeling the top part of the foot for the dorsalis pedis. They then kind of rotate their hands inward to feel the posterior tibs, and they're also feeling the temperature of the skin, and that's a pretty good indication that perfusion is going on. Blood pressure is where we're actually going to take, there's a picture of it, we're going to take a sphygmomanometer. Most people know it as a blood pressure cuff, okay? And you essentially put it over the patient's arm. You could do it at a variety of places. You can do it in the legs. And then you pump the pressure in the cuff up. And what it's doing is essentially shutting off blood flow here. Okay? And then you're going to take your stethoscope and you're going to place it over the brachial artery, and you are going to slowly release the pressure in the cuff. The minute that you have a greater pressure inside the blood vessel and it overcomes the pressure of the cuff, blood will move through and you can hear a noise. That is your systolic blood pressure. So when you take a blood pressure, there's actually 5 phases to it. So this is when you first hear a noise, and that's your systolic blood pressure. Diastolic's a lot harder, because what you're going to hear, because depending on the rate at which you decrease or let the air out of that cuff, because sometimes you're going to hear systolics and it's just a little bit more of a pain, you start to hear different sounds, muffled sounds. And there are changes that occur. Now the weird one is the 5th phase, where you hear nothing. This is your diastolic blood pressure. So your diastolic is the last place essentially, so you hear a noise, then you don't hear a noise. Right at that particular point is where you have your diastolic blood pressure. This is a skill, by the way. It's really funny if you ever look at, start talking about some of the problems that can happen. People that have high blood pressure and you have to get your blood pressure taken all the time. There's kind of an algorithm of taking the blood pressure and how often you should take your blood pressure. And like the final one is the physician is the one who's supposed to take your blood pressure. I don't know how many people here work in the healthcare field, but how many people here have ever seen a physician take a blood pressure? Okay, it's a skill. It doesn't happen to any great degree. When they do it, they don't. So it's not that just because you went to med school that you hear better than anybody else. I'm sure that there are probably CNAs who can do blood pressure better than a lot of other people because they take blood pressures all the time. It's also one of the reasons why it's a good idea, in my opinion, sometimes to do blood pressures manually so you never lose that skill, as opposed to just wheeling the whole cart in. You put the pulse ox on their finger. Why do we put the pulse ox on their finger? Because there's a box to fill in. There's really no reason to have it on there. When I went to urgent care on Sunday for my IT band problem, they were taking, here, let me put the oximeter on. Pink, warm, and dry, don't smoke, don't have a pulmonary history, not here for any shortness of breath. Why are we doing it? There's a box. So, now, these noises have names. There is a name for all the noises together, okay? And it's called sounds of Karate cough, or they're called Karate cough sounds. So if I was to ask you on an exam, specifically it's just a one-word question, a one-word fill-in, it's going to be Karate cough. What are the noises, what are the sounds that you're hearing? It's not that I'm hearing blood entering back into the blood vessel, which is true. The sounds have a name. It's called Karate cough sounds or sounds of Karate cough. It's the muffling that you hear from the first all the way down until you have an absence of sound. Now, I will tell you that the blood pressure cuff size is very, very important. If I have a cuff that's too small, my blood pressure is going to be erroneously high. If my blood pressure cuff is too big, my blood pressure is going to be erroneously low. I think I've told this story before. I had my older sister when she was in the hospital delivering my niece. She was being kept because her blood pressure was abnormal. I happened to be stopping by her room on Mother Baby, and I was working that day, so I was in my scrubs, I had my stethoscope, I had my lab coat on, I'm sitting there and I'm watching this nurse take a blood pressure, and it's like, that's the wrong size cuff. Doesn't really matter. It's like, my sister's being kept here because of her blood pressure, and you're not even measuring her blood pressure correctly. So, went down and had a little discussion with the charge nurse, we got the right blood pressure cuff, lo and behold, she was able to be discharged. So, it is important. So if you don't know how to measure a blood pressure cuff that's correct for the patient, you don't just simply walk in and say, I have infant, child, adult. you have to measure. You have to know the width and the circumference so that you know that it's the correct size for your patient. That's the whole point of anything that you guys do when you do blood pressures, when you do pulses, when you do pulse oximetry, when you do temperatures. You should know how the test is going to be affected and how to do it correctly. Because if you don't, then it is giving misleading information. So a couple last things, then we'll be done for today. Terms I want you to use: hypotension. Hypo means low. Tension has to do with pressure. So this is essentially a low blood pressure. Okay? Low blood pressure is considered 90 millimeters of mercury for a systolic blood pressure. There really isn't necessarily one we look at for a diastolic blood pressure. This is also one of the reasons, if you've ever been involved in an emergency situation, you're watching somebody take a blood pressure, there are times where they don't even have their stethoscope on. Their hand is on the radial artery, and they just simply let the pressure down. And the minute I feel a pulse, that's my systolic blood pressure. In an emergency situation, I really don't care what the diastolic is. So you'll see people write their blood pressure is 90 palp, 90 over palp. In other words, I didn't put a stethoscope in my ear. I felt it. And that's, again, you can't get a diastolic that way. You can only get a systolic that way. So don't be surprised if you ever hear somebody saying that. It's just because it's an emergency and we really don't care about the other one. Now, hypertension, okay, means your blood pressure is too high. So anything that's greater than about 139 for a systolic blood pressure, or greater than 89 for a diastolic blood pressure, those are considered to be hypertensive.
Just the 89.
89 for a diastolic. Now, they are divided up into primary and secondary. Primary means we have absolutely no idea what the cause is. We have a feeling that it has to do with diet, smoking, obesity, lack of exercise, and surprisingly enough, ethnicity. The African American population generally has a much more difficult time with blood pressures than Caucasians do. The other one is we know what the cause is. I might have a tumor that's on my adrenal gland where my norepinephrine is released. And if I remove it, it fixes my blood pressure problem. Most people have the type that we have no idea what the cause is, by about 85%. 85 to 90% have the type of hypertension where we're not quite sure what the cause is. The other have a much smaller, that 10, 15% where we can figure out what it is, fix it, and it's gone.
Which one's primary and which one's secondary?
Primary is the one that most people have. Now, I will tell you that we can certainly put medications on patients to try and lower blood pressure, but the problem is they tend to lower blood pressure overall. So like from a male standpoint, the negative is you might not get an erection because it decreases your blood pressure to the point where you're not able to perfuse, and if you can't perfuse, then you're not going to get an erection. It's going to affect both genders from the standpoint of their ability to mentate. In other words, think. Their level of consciousness could be changed. Okay? So if you have a patient that suddenly you gave them some blood pressure medication and they're, check their pulse, check their blood pressure, because you might have dropped their blood pressure too low. They're not perfusing their brain very well, so they pass out.
But doesn't somebody having high blood pressure, if you give them blood pressure medication, usually kind of bring them more down to a normal level? Because usually they're pretty agitated when they have high blood pressure, it seems.
It depends. Surprisingly enough, most people that have high blood pressure have no idea that they have high blood pressure. It's a very silent disease. It's not until it gets farther along. Now, obviously, it depends on if I have somebody who's in a critical care unit, I can bring their blood pressure down like that. But that's because we're doing it from an IV standpoint. If I give them medication that they're taking PO, generally doesn't have that quick of an effect. Any questions on this? Okay, so we're going to end it there. So tomorrow, kind of be about the same length of time, and we're going to talk about how I get blood flow to the tissue. Again, much less information per day, so please make sure that you're not squandering it away and you're trying to get this all locked into your noggin. Notice,